Medial rotation. Medial rotation. So moving the foot towards the midline so that the toes point inwards. So that is medial rotation. And this movement tightens the iliofemoral ligament. And the muscles that are responsible for this movement are the tensor fasciae lata, the anterior fibers of the gluteus medius and minimus, these ones here, and adductors are medial rotators to the adductor longus, medius, magnus, gracilis, pectineus, all these things, all these muscles are medial rotators also. The medial rotators, mainly the gluteus medius minimus, they prevent dropping of the pelvis on the unsupported side. And they also increase the forward stride during the locomotion, that is during walking, running. And the psoas major muscle, it acts as a medial rotator when the foot is on the ground. And the psoas major becomes a lateral rotator when the foot is off the ground. So here in medial rotation, the psoas major participates when the foot is on the ground. Here there's a point to be noted, that is the Trendelenburg gait, where the hip abductors, that is gluteus medius and minimus mainly, they keep the pelvis level straight, and the pelvis on the unsupported side is maintained by the gluteus medius. If the gluteus medius muscle is weak, which is supplied by the superior gluteal nerve, then the contralateral pelvis loses its support by the weakened gluteus medius. So there is drop of the pelvis on the contralateral side. So when a person lifts the foot off from the ground and there is a tilt in the pelvis on the unsupported side, it is said to be the Trendelenburg sign being positive. So this Trendelenburg sign is the main test to confirm the functioning of the gluteus medius muscle. Lateral rotation. And this lateral rotation is when the foot is moved away from the midline and the toes are pointing outwards, the range being 45 degrees. And the lateral rotation is limited by pubofemoral ligament. Gluteus maximus is the main lateral rotators, and the muscles which are underneath the gluteus maximus are all short lateral rotators, which are the piriformis, the obturator externus, and the obturator internus with superior and inferior gemelli, and the quadratus femoris. Here, as we said before, the psoas major is a lateral rotator when the foot is off the ground. So this is a gross overview of the movements. where flexion, it is the iliopsoas, which is the chief flexor of the hip joint, and the flexion is also done by the sartorius, pectineus, and the rectus femoris straight head. The extension is mainly done by the hamstrings, the first 10 degrees, and the gluteus maximus is a powerful extensor mainly from the sitting position to the standing position. It is against the resistance. The extension takes, the contraction of the gluteus maximus takes against the resistance. And the abduction. Abduction is by the gluteus medius, minimus, and the sartorius. Adduction, all the adductors, adductor longus, adductor brevis, adductor magnus, gracilis, pectineus, and the medial rotation. Medial rotation is mainly done by adductors, that is the adductor longus, brevis, magnus, and also by the medius and the minimus. And the psoas major, when the foot is on the ground, is a medial rotator, and when the foot is off the ground, the psoas major is a lateral rotator. And the lateral rotation is done by the gluteus maximus mainly, and with the muscles which are under cover of the gluteus maximus, which are all the lateral rotators, the quadratus femoris, piriformis, obturator externus, internus, with the superior and inferior gemelli muscles. Coming to the blood supply of the hip joint. So the hip joint is supplied by the blood from the medial and the lateral circumflex femoral arteries, which are the branches of the profunda femoris artery. It also has its blood supply from the foveal artery, which is coming from the ligamentum teres femoris, the tendon, and there is a small contribution from the posterior division of the obturator artery as well. And the hip has two anatomically very important anastomoses, that is the cruciate anastomosis and the trochanteric anastomosis. The cruciate anastomosis is between the transverse branches of medial and lateral circumflex femoral arteries, and a descending branch from inferior gluteal artery, and the ascending branch from the first perforating artery. And the trochanteric anastomosis is between the descending branch of the superior gluteal artery, ascending branch of the lateral and medial circumflex femoral arteries, and a branch from inferior gluteal artery. So, of which the trochanteric anastomosis provides most of its blood supply to the head of the femur, where from this the ascending branches or the reticular branches, they ascend through the retinacular fibers, which are the fibers, the reflected fibers of the capsular ligament that gives way for these reticular arteries, which are the branches from the ascending branch of the lateral and medial circumflex femoral arteries. So this lateral and medial circumflex femoral artery, they form the external capsular ring, the extra capsular ring where they are outside the capsule. Once the reticular branches, they arise from the medial and lateral circumflex femoral arteries, they enter into the joint space along the neck of the femur, and they anastomose to form the subsynovial intracapsular arterial ring. So when there is any fracture of the neck of the femur, there is compromise for the blood supply to the femoral head. because from the foveal artery it is a very minimal supply that's been supplying the head. More of it is from the lateral and medial circumflex femoral arteries, and the superior gluteal artery, it supplies the upper part of the acetabulum, and the inferior gluteal artery supplies inferior and posterior parts of the capsule. Nerve supply to the hip joint. It is supplied by the femoral nerve, that is, nerve to rectus femoris gives a twig that supplies the hip joint, and a branch from the anterior division of the obturator nerve, it supplies the hip joint, and a branch from the accessory obturator nerve if it is present, and a branch from quadratus femoris, it supplies the posterior aspect of the hip joint, and a branch from superior gluteal nerve also supplies the hip joint, and a twig from the sciatic nerve also supplies the hip joint occasionally. And the femoral nerve and the anterior division of the obturator nerve, they supply the knee joint as well. So this explains if there is any pain in the knee, there will be pain in the hip also, which is called as a referred pain. So the pain can be referred to the knee from the hip joint or from the knee joint to the hip joint also. Stability of the joint. So the stabilizing factors here are mainly the acetabulum, which has a deep socket where it almost fits the whole of the 2/3 of the neck of the femur. And this hip joint, the primary function of the hip joint is the weight bearing. And the horseshoe shaped fibrocartilaginous ring, that is the acetabular labrum, it increases the depth and provides a larger articular surface. And the ligaments, the iliofemoral, pivofemoral and ischiofemoral ligaments are very strong and blend with the joint capsule, and most of the fibers of these ligaments are spirally oriented, so that they become tighter and taut when the joint is extended. And the muscles and ligaments, they work in a reciprocal way in the hip joint, where anteriorly the ligaments are stronger and medial flexors are fewer and weaker. Posteriorly, there are a lot of muscles which are stronger, which are the lateral rotators, and the ligaments are weaker. So reciprocally, they stabilize the hip joint, the muscles and the ligaments anteriorly and posteriorly. The weaver's bottom, as we said, is due to inflammation of the bursa because of the sitting posture and constant movement of the leg, where the gluteus maximus will have more friction on the ischial tuberosity. So that is the reason the ischial bursa will become inflamed, and that's what is called weaver's bottom. In Pathers disease, that is pseudocoxalgia, it is a clinical condition where there is destruction, here you can see, and flattening of the head of the femur with an increase in the joint space, which can be very clearly noticed in a radiograph, and this is due to avascular necrosis of the head of the femur. So this is what is the acetabulum margin. This is what is the head. So this is normally, it is almost approximated with a very little joint space, where here the space of the joint is being increased because of the flattening of the head, which is maybe due to the fracture or any of the other features that are responsible for the no blood supply to the head of the femur, causing avascular necrosis of the head of the femur. So coxa vara and valga, they are the abnormality in the neck shaft angle, where the normal neck shaft angle of the adults is about 120 degrees and the children is about 160 degrees. If the neck shaft angle of femur is reduced than 120 degrees, it is called coxa vara. The angle may be almost 90 to 110 degrees, which is usually seen in fracture of neck of femur and Pathy's disease, where there is softening of the neck also is seen. And then when the angle is increased more than 120 degrees, it increases to about 140 degrees, which can be due to congenital dislocation of the joint. That is, when the buttress part of the acetabulum is not developed, that can give rise to congenital dislocation of the hip joint, we said, and can also be due to Perthes disease and due to rickets, where the softening of the neck of the femur can happen. So the fracture of neck of femur, it is more common in individuals more than 60 years of age because of the femoral neck becoming weak and brittle due to osteoporosis, which is an age-related disease. Or it can be, the fracture can be due to indirect violence of a trivial nature, where a person, he falls on the ground and cannot get up. The affected limb is much shortened and rotated laterally. When there is fracture of neck of the femur, the limb is rotated laterally. So there are 4 types in the fracture of neck, where it is subcapital, cervical, in the middle, basal, near the trochanters, and pretrochanteric fracture, which is distal to the greater and lesser trochanters. So when there is fracture, the retinacular vessels, which are derived from the lateral and medial circumflex femoral arteries, the blood is hampered. The blood supply to the head of the femur is hampered. So the pretrochanteric fracture, the extracapsular fracture it is, because the capsule is attached to the intertrochanteric line and little more medial to the intertrochanteric crest posteriorly. So the extracapsular fracture will not damage the retinacular vessels. Hence, the avascular bone necrosis of the head of the femur does not occur. This is the extracapsular fracture or pretrochanteric fracture. But if the fracture is intracapsular, maybe subcapital, cervical, or maybe even basal, then there can be damage to these retinacular vessels, which are the branches from the medial and lateral circumflex femoral arteries, which hamper the blood supply to the head of the femur, causing avascular necrosis of the head. And if there is intracapsular fracture of the neck, the affected limb here, you can see, is shortened and laterally rotated. That is, toes, they point laterally. This can happen because the head of the femur, it separates from the shaft, and the shaft rotates independently of the head and is pulled by the lateral rotators, which are the strong muscles that are present posteriorly than the muscles that are present anteriorly. So the gluteus maximus and the short lateral rotators will rotate the femur laterally. The muscles that are attached to the hip bone and femur, they pull the femur upwards, making the limb short. That is the reason whenever there is fracture of neck of the femur, the patient presents with shortening of the limb and the lateral rotation of the foot.